Basic picture of a cervix, which is actually here. It was kind of hard for me to find a picture for parametria, but parametria is pretty much over here, like the fat between the bladder and the uterus. If you start to feel a mass here, then that's a different type of staging. The incidence of cervical cancer, the mean age is about 48 years old. It's more in minorities and low socioeconomic status. It's predominantly in Hispanics, African American, Native Americans, Alaskans. Those without routine screen have a higher incidence of cervical cancer. Globally, cervical cancer is the fourth common cancer and the fourth most common cancer-related death among women. The incidence of cervical cancer is expected to decline among women who get the HPV vaccine. HPV is responsible for 99% of cervical cancers. Although it is estimated that up to 80% of sexually active adults are exposed to the virus, most individuals clear the virus. More than 40 strains of HPV have been identified. 16 and 18 are identified in more than half of cervical cancer cases. Many of the risk factors for cervical cancer are the same as those for STDs. Early sexual activity, less than 18 years old, multiple sex partners, more than 5, sexual partners who've had multiple sex partners, cigarette smokers, which is more related to squamous cell carcinoma, immunosuppression, low socioeconomic status, and long-term use of oral contraception. Usually the reason why people would say oral contraception would be a cause is maybe because patients don't use barrier methods. Here are the risk factors that were previously discussed and explained. Signs and symptoms of cervical cancer. Usually patients will come in presenting with signs of irregular or heavy bleeding, bleeding after intercourse, or change in vaginal discharge to watery, mucus, purulent, or odorous fluid. Late symptoms would be pain radiating to the flank or leg, pelvic pressure, and urinary changes such as hematuria, vaginal hemorrhage, and development of uremia. A pelvic exam should be performed for any woman with symptoms of cervical cancer. On speculum exam, the cervix may appear normal or have an obvious visible lesion. PAP and HPV co-testing are used in combination for cervical cancer screening. Abnormal results may need a colposcopy of the cervix. Abnormal results may need a colposcopy of the cervix. A colposcope is a magnifying device looking at the cervix. If the cervix appears abnormal, biopsies of the cervix or endocervical canal are obtained. If the biopsies confirm malignancies, a more comprehensive procedure such as conization with or without a hysterectomy may be indicated. A bimanual pelvic or rectovaginal exam is required to assess the tumor size and vaginal or parametria involvement. Cervical cancer consists of mixed cell types. Squamous cell represents about 80%. Adenocarcinoma represents 20%. HPV 16 and 18 are the most virulent strains causing cervical cancer. HPV 16 and HPV 18 are seen in 59% and 13% of squamous cell. HPV 16 is 36% and 18 37% for adenocarcinoma. Squamous cell carcinoma has declined due to the effective screening, but the incidence of adenocarcinoma has increased over the past 30 years. Pap smear is less effective for detecting this type of histology. Cervical cancer is staged clinically because surgical staging is not done in third world countries where there is an increased incidence. International Federation of Gynecology and Obstetrics, also known as FIGO, is also used for staging. In stage 0, tumor is confined of the surface layer, the cell lining of the cervix, also called carcinoma in situ. Stage 1, there's an extension deeper into the cervix with no spread beyond extension to the corpus is discarded. 1A, invasive carcinoma may only be diagnosed at microscopy. 1A1, stromal invasion 3.0 millimeters deep and extension is 7.0 millimeters. 1A2, stromal invasion is more than 3 millimeters and 5 millimeters with the extension of less than 7 millimeters. 1B, clinically visible lesions limited to the cervix or preclinical cancer higher than stage 1A. 1B1, clinically visible lesion, 4 centimeters is the greatest dimension. 1B2, clinical visible lesion is more than 4 centimeters in greatest dimension. 2, cervical carcinoma extends beyond the uterus but not to the pelvic wall or the lower 1/3 of the vagina. 2A, no parametrial invasion. 2A1, clinically visible lesion, 4 centimeters in greatest dimension. 2A2, clinically visible lesion more than 4 centimeters in greatest dimension. 2B, with obvious parametrial invasion. 3, extension to the pelvic wall, involvement of lower 1/3 of the vagina or hydronephrosis or non-functioning kidney. 3A, involvement of lower 1/3 of the vagina with no extension to the pelvic wall. 3B, extension to the pelvic wall, hydronephrosis, or non-functioning kidney. 4, extension beyond the true pelvis or involvement of the bladder or rectal mucosa. Biopsy is proved. Bullous edema does not convey stage 4 disease. 4A, spread to adjacent organs, which would be the rectum and the bladder. 4B, spread to distant organs like the liver, other lymph nodes, the lungs. Here's another view or a visualization of staging. Methods used for FIGO staging are limited to colposcopy, biopsy, conization, LEEP, ECC, endometrial curettage, cystoscopy, proctosigmoidoscopy, barium enema. In the United States, imaging modalities and surgical staging are also used to select treatment options. Surgical staging for women with low-level disease and microinvasion disease may include fertility-sparing approaches or radical trachelectomy, which is also known as a complete removal of the cervix. Sentinel lymph node mapping remains controversial, but may be useful for early-stage disease. Early-stage treatment for cervical cancer includes stages 1 and stage 2A disease. Primary treatment is surgery or radiation therapy. Fertility sparing is conservative approach with a cone biopsy and possible pelvic lymph node dissection and radical trachelectomy, depending on surgical margins and LVSI. A trachelectomy removes the cervix, parametrium, and 2 centimeters of the vagina. The uterus is left intact. A cerclage is helped to maintain the pregnancy. If pregnancy goes to term, the patient will deliver via C-section. If the patient decides that she doesn't want to have any more children, hysterectomy is recommended. The choice of simple or modified radical hysterectomy with pelvic lymph node dissection depends on positive surgical margins and LVSI. Analysis of stage 1B and 2A disease should be individualized to determine whether para-aortic nodes or sentinel lymph node mapping is suggested. No adjuvant therapy is indicated if lymph nodes, surgical margins, or parametria are negative. Treating bulky tumors with radiation therapy, brachytherapy, or cisplatin-form chemotherapy instead of hysterectomy is an approach for selected patients. Controversy remains about whether a complete hysterectomy is required after radiation therapy and chemotherapy. Studies show a decrease in the rate of pelvic recurrence, but more morbidity and no overall survival benefit. In the advanced disease, which is stage 2B and 4A, some clinicians categorize 1B2 and 2A2 as advanced disease. We recommend CT and PET scans, chemoradiation with cisplatin, followed by brachytherapy. Additional treatment decisions such as extended field radiation therapy may be determined by lymph node status and periaortic involvement, which would be noted from the imaging. Patients with recurrent disease may be candidates for radiation therapy depending on how much RADS was used on the field, chemotherapy, or surgery depending on the extent of spread or prior treatment. Check how much radiation dose was given at the site to see if it's appropriate. Local recurrence after chemoradiation therapy may involve surgical intervention with an exenteration, which means that you remove the bladder and the rectum. So now the patient will have a pouch to urinate and to defecate. Patients with distant metastasis at presentation or a recurrence is usually given systemic chemotherapy. Please see NCC guidelines for updated recommendations. Things change often. NCCN already has information for 2024. They're always keeping updated. As with radiation therapy, please always keep up to date with the times. Just like, Fat Joe says, yesterday's prices is not today's prices. Patient selection and radiation dose are determined by patient risk factors such as positive surgical margins. Chemotherapy, combined chemotherapy and radiation therapy have been shown to decrease the death rate for cervical cancer by up to 50% compared with radiation alone. Chemotherapy is usually cisplatin given weekly while the patient is receiving daily radiation therapy. Prognosis depends on the stage of disease, recurrence, and comorbid conditions. The 5-year survival rate for stage 1A is 95%. Stage B or 2A is 70 to 85%. Stage 2B is 65%. Stage 3 is 40%. Stage 4A is 20%. And stage 4B is 10%. Looking back at survival rates, the earlier detected and treated, the earlier and better outcome for survival rates. So this is why it's very important for patients to follow up with abnormal PAPs. Just because you're not taking care of it or you act like you don't see it doesn't mean that it's not there. When you manage the treatments for cervical cancer like chemo and radiation, that cancer has a lot of symptoms. Sometimes the symptoms are related to the treatment. Patients will report bleeding, pain, urinary bowel obstruction or invasion, vaginal function issues. All right. So for an NP standpoint, client safety and risk reduction is very important. You have to identify high-risk populations, limit sexual partners, educate on HPV vaccinations, check for regular examinations, try to have your patients stop smoking. Manage the treatments. Cancer-related symptoms can include significant bleeding, pain, urinary or bowel obstruction, complications of metastatic sites of local structures, lymph nodes, and distant sites. If the patient had abdominal pelvic surgery, alterations in urinary, bowel, and vaginal function. Sometimes the patients have percutaneous tubes. Assess the catheterization. Check for urinary tract infection. Check for constipation, bowel obstruction, and shortening of the vagina from radiation. Pre and post-op care is also important to teach the patients. It includes bleeding, infection, DVTs, lymphedema after lymph node dissection, which is kind of rare because there is not too much nodes are removed, especially during sentinel lymph node dissections. You should also check for patients who had history of radiation therapy. There'll be changes in bowel and urinary function. It may include loose stools, obstructions, fistula formation, ulceration, pain, radiation cystitis, and urinary frequency and retention because the bladder is not holding as much as it used to before. It got smaller, so the capacity to hold urine is minimal, and that's why the patients always have to void a lot. Um, Please check NCCN for the most updated medications that are used, but mostly it's cisplatin. Cisplatin, you got to make sure you check the patient's renal function. When they're getting chemo, you check their hepatic function. Make sure that the patient has enough antiemetics, Zofran, Reglan, to prevent them from vomiting. Make sure that there's no hypersensitivity reactions. Check for A and C for myelosuppression. And also assess for neuropathy. Sometimes the patient will say they feel numbness, tingling of hands and feet. Make sure that they're able to button their shirt. Make sure that they're able to put earrings on their ears. If they have tingling in their feet, make sure that they are not tripping, because those are a different kind of grade, and that might mean that they need to decrease their dosage for the chemo, cisplatin. Assess for signs of recurrent disease. Make sure that you always ask, does the patient have any pain, changes in bowel, bladder, any vaginal bleeding, leg swelling, groin pain, or groin mass changes? Abnormal follow-ups need CMP, CBC, another CT, or PET imaging. Can't forget about the sexual and reproductive function. Even with fertility-sparing treatment, changes in vaginal function may still affect sexual function. Encourage open communication with the patient, provider, and sexual partner. Contraception should be used during and for a period after active treatment, depending on treatment type. For non-fertility sparing, discuss infertility with patient, their partner, and provider before treatment starts. Use vaginal dilators, different sexual positions, and vaginal lubricants. Well, that was a mouthful. I hope you got as much information that you needed from here if it was helpful. If it wasn't helpful, please, you don't have to have any negative comments. But this was basically for me to study and be able to record and hear myself, because sometimes I don't like to read. And another way to make me learn is to just hear it over and over again or have some visuals. Thanks.